The broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to HDSA's Caregivers Corner webinar series. Today's webinar is going to be presented by Ann Lesserman, who is going to discuss Cognitive Strategies, Part 2, A Social Work Perspective. Before I invite Ann to begin, I'm going to go over how to ask a question as well as how to access this webinar after broadcast. All questions will be answered following the presentation. However, you can send your questions in at any time. In order to send a question, just go to the control panel that appears on the right-hand side of your screen, type in your question, and hit the send button. This webinar will be available for viewing approximately 1 week from today, and you'll be able to see it on the HDSA national website, www.hdsa.org. You'll also be able to view the slides from this presentation. To access the presentation, go to the HDSA website, scroll down to the home page to the frequently used shortcuts section on the right-hand side. You'll see a link to the Caregivers Corner webinar series, and just press that link, and you could view the webinar as well as access the PowerPoint. You can also view our older webinars in the Living with HD section. And now I'm pleased to introduce Ann Lesserman. Ann is a new HDSA regional social worker for the Mid-Atlantic region. She was previously the care coordinator for the HDSA Center of Excellence at the University of Iowa, where she was for 9 years. Ann has experience in the role of educator, advocate for families, clinic coordinator, support group leader, and nursing facility liaison, as well as recruitment and retention of HD participants and family members in HD research studies. Ann is also a past recipient of the HDSA Patient and Family Services Award. And now I'm thrilled to turn it over to Ann.
Thank you, Jane. So I'm going to be talking more about cognition, kind of a follow-up on Eric Johnson's talk last month. And I wanted to say that my education came from my experience at the HD Center of Excellence at the University of Iowa with Director Jane Paulson, who's a neuropsychologist. And it's because of her work with the Predict HD project that I learned a lot about HD through the lens of cognition. And I really appreciate that perspective that I learned. And I want to thank the families in Iowa and the Predict HD participants that I've worked with over the years. Thank you. Okay, so presentation today is for informational use only. Recommendations are for general guidelines only. Attendees are encouraged to consult with their primary care physician, their neurologist, other healthcare providers about any specifics that may be mentioned as part of this presentation. I have no financial disclosures to make. So, okay, here we are. A chair, a stool. HD is a neurologic disorder, and it's currently diagnosed with motor signs by a neurologist. We know with the current research that's being done that there may be early signs of the disease prior to any motor signs. So the important piece of this slide is the 3 components of HD, which are motor, behavior, and cognitive. So you might think of these as forming a 3-legged stool, and I'll be focusing today on the cognitive issues. But there is an interplay of these HD symptoms as the disease progresses. So imagine if one of these legs is unsteady or loose, it becomes kind of wobbly. It becomes hard for the stool to continue to provide the best support. So again, as the symptoms progress, that stool becomes much more wobbly. I'm not going to talk about specific stages of illness, but rather that it's important to know that the cognitive signs may appear as some of the earliest signs and will likely increase as the disease progresses. Other symptoms like motor and behavior may start at different times during the disease process. Okay, so why this emphasis on cognitive symptoms? One big reason is that these cognitive issues are often the earliest, and they're often the most understood of the symptoms. And they cause problems in relationships. They cause problems at work. They can cause problems in families. And it's important that you, as the caregiver, become the HD expert and help to educate your family and the network about what these cognitive symptoms are and what the problems are that could happen with them. It's also important to understand how these cognitive issues may affect behaviors. What are the cognitive issues that are triggering problem behaviors? And this may help make it easier to either prevent these issues or at least help you cope. So an example of this might be saying, so instead of saying, as a caregiver, my wife has outbursts, so that's describing the behavior. Instead, it might be more helpful to say, my wife has become very sensitive about how her meals are presented. So you're saying the cognitive changes have changed the way she focuses her attention. And then you say, she overreacts when things don't look the way she likes it. So that's a different way of saying my wife has outbursts. You, as the caregiver, have learned about her cognitive changes, resulting in her specific likes and dislikes, which may be displayed in her behavior. It's important to talk about some strategies to handle these issues. Okay, so next. All right, so I'm going to, some examples of cognitive changes. We talk about the way patients with HD learn. So there's problems with attention, there's problems sequencing complex tasks, and difficulty learning new tasks. So some strategies might be breaking these complex tasks into smaller steps, writing down the steps, practicing the steps, and then giving a chance to learn. So let me give you an example of that. So if you said to your person with HD, I need you to sweep the steps and sweep the leaves off the front steps today while I'm at the grocery store. Seems like a pretty simple request. Go get the broom, sweep the steps. But you may want to break those steps into even smaller steps. Remember the broom is in the front hall closet. Remember you need to unlock the door and the chain to open the door to get outside to sweep. So there may be some very small steps that you can talk about that can break that, sweep the steps into little steps. Other cognitive changes, memory. So this may mean difficulty learning new information, and it may be having difficulty recalling information. So that information might be there to get to, but it may be difficult to trigger it. So things like providing cues, hints, filling in some missing words for the person. Avoiding open-ended questions. So instead of saying, what do you want for dinner, it may be easier to offer choices of alternatives. Would you like macaroni and cheese or would you like meatloaf? Trying a to-do list with written reminders. And then an important thing throughout is maintaining a daily routine so people know what to expect. Okay. Visual spatial deficits. This could mean someone who has impaired body image, a loss of ability to orient themselves visually, difficulty reading visual cues. And I know Eric talked about the visual cues in the last presentation. I talked to someone who was very early in the disease to try to understand this visual spatial stuff from early on. And they talked about walking off of a curb. So imagine if you had some problems with your visual spatial abilities and you were walking down the street and you get to the end of the block and you decide you're going to cross the street and you have to think about what the distance is from the edge of the curb to the bottom, how deep it is. And so imagine the difficulty to try to manage that just a step off the curb. So some things to try would be orienting to new places. So I know it's pretty common in nursing homes with people with cognitive difficulties that they give tours of the facility, they put people's names on the door, and maybe the names stick out so that when you walk down the hall, you know that Joe Smith, there's my room. Using signs, and avoiding independent travel to new areas. Another example of this, there was a family that I worked with that liked to go on vacation, and they always wanted to include the person with HD in the family vacation. And it got to be difficult because although he was glad to go, he would go back, he would say, you know, I don't want to stay at the beach right now, I'm going to go back to the room, and it got to be very difficult for him to find his way back. That's another example of the visual spatial difficulties somebody might have. There may be even difficulties like distance between when you talk to somebody face to face, and maybe they get in your face too much, or maybe they back away so much that you can't really have a conversation with them. This is all part of the visual spatial deficits. Okay. Bradiphrenia. So this is a definition of speed of processing or slowed thinking. So brada meaning slower and phrenia meaning thinking. It's very helpful to allow a person enough time to answer or react, and trying to be patient during the long pauses if somebody's trying to bring their words to the front. Maintaining focus on the person, limiting distractions in the environment, and also being aware of person's personal preferences. So one of the examples I have about this, Jim Pollard, who is a past director of several HD inpatient programs in Massachusetts, gives a really good example of this. And you know, this is a guy that knows a lot about HD, but he remembered a particular new patient that came to his facility, and he remembers that every day he'd come by and he'd say hello to her on his way to his office, and he never got a response from her. And after several days, he decided to ask the other staff about how she was adjusting to the facility. And he made the assumption, because she didn't respond, that she wasn't doing very well and that she wasn't very happy. But the staff told him that she indeed did respond to him, but that he was always speeding by and never stopped to hear her response. So the next morning, he slowed. He said good morning to her. And he waited, and he waited, and he waited, and finally she responded to him. So that was a good lesson for him, and I think a good example of making assumptions without kind of checking out the reality of the situation. I want to talk about executive functioning. So these are some of the changes that happen in the frontal lobe that impact behaviors. I'm going to talk specifically about HD, but this happens in other neurodegenerative disorders as well. So I'm going to be talking about, I'm not going to be talking about all of these, but I'm going to talk about some of them as we go along. So think about the executive functions as, imagine this as the conductor of all your cognitive skills. And it's a set of processes that help us connect past experiences with present action. So the things that we've learned and the things that we've learned over time, and then help us to present things currently. So I want to use the example of somebody going on a very long car trip. And what does the past experience tell you about what you will need? And hold on a second. I'm going to. So the filtering, organizing, and prioritizing. So imagine you're going to go on this car trip, and you know, you're going to want some maps. You're going to want some snacks because the trip is going to take a long time. You know you're going to need some snacks for your child that gets a little car sick. So you know she can't have any books to read while you're riding in the car. So there's a long list of things that you would need to think about and organize to take this trip. You know, making sure that the gas tank is full, making sure that the newspaper's been stopped, and that somebody's taking care of the cat, and that the mail has been stopped. So there's a very long list of things that you need to think about as you're going to take this trip. So structuring the tasks would be a helpful way to try to help somebody prioritize, trying to organize the information, trying to keep with the routine, and filtering out the distractions. So there's that one again. So this quote, I know she knows how to do this. She's done it 1,000 times. So I heard this from the spouse of a person with HD. This was a person who really liked to bake, and she liked to bake chocolate chip cookies, and she'd done it thousands of times. But he knew that there were problems with her executive functions, with her organizing and prioritizing, because she couldn't remember how to do it anymore. She couldn't remember, you know, that she needed to take out the ingredients that she was going to start with. She couldn't remember that she needed to take out the bowl and the mixing cup and the measuring spoons. And you know, the cookies just didn't taste the way that he remembered them. Okay, executive functions, beginning and ending activities, initiation, getting started. In early stages of HD, I would hear a lot about initiation. Sometimes more around the time of diagnosis when there was some movement. And often when a patient decided that they were going to retire earlier, they decided it was time for disability. So they would be at home, and maybe the spouse would be going off to work, and the spouse would leave this list of things that she wanted her husband to accomplish while she was at work. And she would come home, and he would be sitting in the same place that she left him that morning. So there's a couple ways that wife could respond. She could respond by saying, you know, you're a lazy bum, and I've been working all day, and you've gotten nothing done. Or she could say, well, I know that you can get these things done if I help you, so let's get up, let's get the dishwasher emptied, let's start to make dinner together. And knowing that the spouse could help if she helped get him started. So deciding whether this is a problem with initiation, whether this is a problem with apathy, or maybe this is a problem with depression, and trying to kind of figure out what this might be. You know, this would be a good question for your care providers to help you kind of figure out, you know, what is happening with your HD person. You know, she's bored, she sits there all day. You know, does the patient seem sad? You know, is it depression, or is it apathy? It's a little harder to treat. Or is this, you know, let's see if we can help get the person moving and try to get them started, trying to get them up from their chair. He won't do anything we ask him to do. So another example of how can we get this guy going so he can participate in the family. I think one of the issues about this initiation piece is to be careful about making judgments, you know, to moving away from that, you know, this person is just lazy and they're not helping anymore, but that this is really a part of brain disease. Okay, executive functions, impulse control. So we know that there are changes in the brain that make it difficult to control impulses or reactions. And sometimes those reactions may come out a lot bigger than what it seems is necessary for the event. The anger may certainly be justified, but if it's lashing out physically or emotionally abusive, then that's certainly a problem. So it's important to help redirect from that anger source to avoid ultimatums. You know, you need to do this or else. Trying to keep yourself and the environment calm. Trying to identify what the triggers are. You know, what are the things that really seem to anger this person? And then the final piece is that safety is a priority. So this picture, I think, is interesting on a lot of levels. So you can certainly see from looking at these two that they're not happy. You know, their arms are waving in the air. They're both talking at once. Their facial features look pretty angry, and they've even disturbed the cat. So even though this guy certainly looks like he's the most angry, it may be difficult for the person with HD to sort of judge that angry look. So that problem with reading facial cues may be a problem, and you need to think about that as you try different ways to handle these situations. Monitoring self-awareness. Repetition, getting stuck. Some strategies to try are using distraction to shift attention away from the repetitiveness, trying to use humor to get somebody unstuck, or even establishing a time limit. So my first experience with a person with HD, when I first started at the center back in 2003, there was a man in his 40s who was in the hospital waiting for nursing home placement. And I saw him every day for a couple of weeks. My schedule was pretty loose back then, and I had a good example of an HD guy that I could talk to every day. And so I saw him every day for a couple of weeks, and he always started his conversation about how he felt about his wife. And he had some pretty nasty choice words for her. And after several days of listening to his rant, I decided I would try finishing the conversation that he started. So he would start by saying, and I'd say, yeah, I know. You know, she's difficult, da-da-da-da. And then I would try to move the conversation on. And then as I got to know him better, I would tease him about what I knew I was going to hear. I was like, yeah, I know. You're going to tell me that she's such and such, and try to move the conversation along that way. And we ended up having a pretty nice relationship. And I, at times, actually could move him along, although I did have to hear it every time I met with him. Unawareness. So unawareness is different than denial. Denial is the inability to cope with distressing circumstances, but it tends to recede over time. Unawareness is what we might call an organic denial. These are changes in the brain that can last a lifetime. So this anosognosia is a lack of awareness of symptoms, not able to recognize their own deficits, unable to evaluate their own behavior, and maybe unintentionally non-compliant. So some of the strategies to try is to accept this as untreatable. I mean, you're not going to change somebody who decides that they don't have HD. There's not going to be an aha moment for them when they say, "Oh yeah, you're right. You know, these are the symptoms of Huntington's disease, and that's what I have." That's not going to happen. So you may, you know, why is this important to be addressed? Why do we need to talk about, you know, that the person has HD and they need to say, yes, I have HD? It may be helpful to ask the person to choose incentives for their compliance. So, you know, if the person says, you know, I'm not taking a shower and I'm not going to take one ever again, you know, you have to come up with some strategy to get them to do the things that you want them to do, and that HD doesn't need to be mentioned as a part of that. Um, an example of that might be somebody who is having some balance problems, and the doctor suggested that they start to use a cane. And you say, well, the doctor said you have Huntington's disease, you have balance problems, and you need to start using a cane so that you don't have these falls. Like, well, I don't have Huntington's disease. I don't need to use a cane. So there may be another way around that to say, well, you've got these bruises from times that you kind of had some falls, and let's try to use this cane so we can avoid some of that without the mention of Huntington's disease. So the levels of unawareness. So this could be not explicitly denying their deficits, but never mentioning it and appear unconcerned, actively claiming that they don't have HD and that these deficits have some other causes, unaware of HD. They describe their experiences inaccurately using some past events, like so somebody's having some fender benders. It's like, I'm a truck driver and I've been driving for 45 years and I never gotten a ticket, and so that might be an example of somebody who's unaware of their HD and their problems. And then the unaware and confused with their mental decline. Now I want to give a couple examples of that. So the example of a woman who is living alone in her apartment, and she notices a smell coming from her sink and decides that the way to deal with this problem in the sink is to have some bleach to clean it out. So she goes to the store and she buys 5 gallons of bleach, and for every time that she uses the sink, she brings out this bleach and she uses it on the sink and she uses it on the floor, and it's affecting her hands. And she's made some assumptions about her sink and the smell, which may or may not be real, but she draws erroneous conclusions about that smell and how she's going to make it better. And then she makes some unfortunate choices by buying gallons and gallons of bleach, and has a total lack of awareness of how all of this happened. This could also happen for a person who might get arrested for their behavior. Someone who's riding their bicycle at night, weaving along, and the police pick them up, and it's like, oh, well, officer, I was just going to buy cigarettes. And it's like, no kind of putting together that riding your bicycle at night, weaving around, may cause some attention that you didn't really want. So these are the kinds of issues that arise with cognitive changes. Some anger and frustration, the question of why can't I live alone, driving, continuing to work, caring for small children, issues of smoking. I don't have HD, or even my HD is cured. I went to the doctor, he gave me that blueberry medicine, and now I don't have HD anymore. So family response. Relationships may be more contentious as roles in the family change. Family members need to refine and organize their roles to adapt to a changing situation. Logic may not be the most effective tool. Change in the equity of a relationship. And as these cognitive changes happen, there are another level of loss, changes in family dynamics, and the resource availability may also be a problem. So I know I've mentioned this once before. Insight might not be the central goal. So if the goal is, I want my loved one with HD to say, yes, I'm having these problems because I have Huntington's disease, that probably is not going to happen. The person with HD may never accept the disease. It's important to develop a contract for compliance, but sidestepping that awareness issue. Avoiding power struggles. Consider that the person with HD, that's what PhD is, person with HD, may not always be the inaccurate reporter. So in other words, certainly the person with HD may have some valid points about what's going on, and those things need to be considered. And Amy Chester will be talking more about family dynamics in the next webinar next month. So caregivers looking for help, join a support group. Learn how other people are handling issues. What are they doing that you're not doing? Or what are you doing that is better than somebody else? This is helpful. Finding a local expert who will provide information that the loved one respects. Maybe that's somebody in your family. Maybe that's the social worker at the Center of Excellence. Maybe it's the support group leader. But finding somebody who may be the one who's the respected one to be able to tell somebody what they can do. Seeking a therapist for yourself. Creating a support system possibly separate from your family. Being clear about your needs and who can best help with them. So you know that there are some people that are fun to have a drink with and have a laugh with. And then there are people that if you want a meal, that might be a different person. So be clear about your needs and who can best help with those. Learn about Huntington's disease, just like you're doing today by listening to webinars and looking at websites. Learn everything you can. And learning how to communicate with healthcare professionals who may or may not know much about Huntington's disease. So I gave a talk this weekend on nutrition, and sort of the basis of that talk is bringing in a lot of different professionals who have expertise in different areas, who may not know specifically about HD, but bring some little piece of information that's helpful as you deal with the issues that come along with Huntington's disease. Accepting your feelings, and there may be a very wide range of them: anger, guilt, resentment, grief. Find somebody to talk to so you don't feel so overwhelmed. Don't try to do it all. Understand what your needs are, and don't be afraid to ask for help. Attending to your own needs is critical. Getting good exercise, eating right, not drinking or smoking excessively, getting good sleep, taking care of your physical health, because if you're not taking care of you, then who's going to take care of your loved one? And then figuring out what the resources are in your community, and picking and choosing the things that might be the most helpful for you. So here are some past webinars that kind of add on to some of the things that I've said today. So Eric Johnson's had a couple past webinars. Mary Edmondson's on caregiver interventions, Marcia's caregiver coping strategies, Care for the Caregiver, Lisa, a social worker in California. So those are some other things to look at to kind of put the pieces together. And then again, next month, Amy will be talking about family dynamics. So thank you for your time and attention. And I hope that there's some questions.
So now Anne is going to take some questions. As a reminder, to send a question, you type it in to the question pane on the right-hand side of your screen and hit the send button.
I see a question. I can't see the top of it, though. Okay, wait a second. Here it is. Okay. Can I open this box bigger?
Yes, and to open the box bigger, you undock it by pressing the button to the left of the X.
Okay, hold on a second. I just, oh, there it is. Okay. So say that again, open it to the box on the left.
So,
sorry about this.
It's okay, please bear with us. So you will see next the little X, there is a little right angle with an arrow to the left, and you click on that, then you can undock it, and then you could just make that bigger, and then you'll be able to see the questions.
All right, so somehow I can't get this box to open bigger.
Okay.
Oh, I'm sorry. I mean, I can see like tops of the.
In order to get it bigger, what you do is you want to just go to the side and drag. Just go to either side.
Yeah. Okay. All right, what type of cognitive exercise could be used to improve the cognitive issue? Well, so you know there's no medicines for cognitive issues. You know, some people talk about you know, doing mind-healthy exercises like puzzles, crossword puzzles, things like that. Not a great answer. The whole part about trying to stay active and keeping somebody engaged, you know, whether it's, you know, if their thing is watching TV, that it's not always soap operas, that they're watching maybe Animal Planet or something where they're, or History Channel where they're actually learning something, and not, and that the activities are a little more cognitively challenging. Okay. My son sleeps until 3 or later when he doesn't have anything to do, and I can't get him to change this habit. Any suggestions? I mean, the sleeping certainly has some restorative powers, as well as, you know, so it sounds like that that it's difficult to get this person moving when you want to get them moving. Maybe coming up with some incentive to get him out of bed. You know, if it's watching the rerun of a favorite of the last night's football game, or it's going to have an ice cream sundae, trying to come up with some incentive to get him to move. And maybe his sleep pattern is just shifted, and maybe maybe you're just going to need to go along with that. Okay, hold on. I'm still trying to figure out how to get these questions open. If a person with HD initially accepts that they have HD, is it possible that this can change as the disease progresses? I would say yes, it is possible that could change as the disease progresses. But again, it doesn't need to be the focus of the issues. That you need to work around them, whether they say that these things are HD or not. So some examples of sidestepping. So the example that I used of the guy that was talking about his wife, and an example of sidestepping might be, I know you're going to talk to me about her, and I know you're really upset with the way she treated you and that she's not allowing you to see your kids, but we need to talk about your future placement and da-da-da-da-da. So acknowledging what the issue is that you know that they're going to talk about, but trying to move it along. I hope that answered some of that. Okay. My husband was diagnosed 7 years ago, and although many cognitive issues talked about in the webinar are real for us, I have not had experienced negative or difficulty behaviors, thankfully. Is that something I should expect at some point, or is it possible he will remain a pleasant person who simply has cognitive challenges? That's a really good question. I hope that's the case, that he's a pleasant person who simply acknowledged that there are some problems going on. It's there, you know that every HD person is their own HD person, their own HD, and it's hard to say whether he will have changes over time or not. I hope he stays as pleasant as he is right now. Is it common for HD patients to not want to take meds, and what can you do about it, especially if they have a history of aggressive behavior? Yeah, I would say it is common for patients who decide they don't want to take their HD medications. So imagine if you didn't think you had HD, what are you taking medications for? So I mean, this can really be a problem. So this is an example of having to figure out some strategies of them taking their medications, even if they think they don't need them for any reason. Let me think if I can come up with an example. So it's, you know, it's going to have to be figuring out a way to get the person to be compliant. And again, it might be trading off for some things that the person really likes to do, or the things that somebody really likes to eat, or you know, visiting with their grandchildren, or taking a drive in the country. You know, trying to come up with some situation that you can trade for, you know, you need to take these meds. It's also a good question to talk with the physician about, the physician who's prescribing the medications. You know, yes, we know he needs to take them. He doesn't really want to. What can we do about that? Okay. Okay, so I'm going to move on to the next question. Although the PhD is slow to understand and communicating, what is happening with their memory? Do they lose a lot of brain retention? It seems that with patients with HD that sometimes the information is there. It's just slow to retrieve it. So, you know, certainly as the disease progresses, they may lose some of that retention, but you know, it's different with HD than it is with Alzheimer's. So with Alzheimer's, people can't recall things, but with HD, they often can. It's just sometimes can be very slow. So sometimes you just have to be patient. I hope that answered that. You guys are asking good questions. I feel stumped. Okay. Do you have experience with a person with HD caring for children in the home? If so, could you comment on the benefits for the PhD and the children plus recommended strategies? It's really important if somebody's caring for children in the home to understand kind of where the person is at and what's happening with these cognitive difficulties, and also how old the kids are. So you know, this is a very specific question that you may need to be talking with your healthcare providers about. You know, the main issue is safety for the kids. You know, is this a person with HD that has a lot of movement and some stumbling things, and they're caring for a little baby? You know, you don't want somebody trotting through the house who's bumping into walls when they're carrying a little baby around. So, you know, this is a specific question that I think you're going to need to talk to some professionals about. But again, the main issue, I think, is safety for everybody. If I leave a list of things I want my HD husband to do, he gets angry. How do I ask him to do some chores without getting him angry? Well, I mean, I think one of the things you could say is, you know, we have things that we need to do as a family together. There's some things that I do, and there's some things that you do, and we need to figure out sort of the balance of who does what during the day. So trying to get the person to cooperate as, you know, here are the things that I do, and here are the things I need you to do. And being appreciative of the way that the person can help the household. I hope that helps. My husband has turned his TV turned up all the way. His hearing is okay. Could this be because he has trouble interpreting what is being said? Yeah, I mean, it may be that this is also a way for the person to sort of get rid of the distractions around him. So if the TV is really loud, then that's all he's hearing, and everything else is kind of out of the range. So I think it could be, one of this could be you're right, that he has trouble interpreting, and the other piece could be that it's a way to get rid of the distractions around him. Okay. How do you intervene with a family whose wife has HD and thinks she should have complete control over the family, showing poor judgment, anger toward the family, unwilling to give up any power to her husband for decision making? 2 teenage children involved, driving them all crazy. It may be helpful to get a objective person in the mix with this family. So I'm not sure if this question is coming from another family member or whether this is coming from a professional. But I think I would try to get the family together. Hold on a second, I'm going to read through it again. How do you intervene with a family whose wife has HD, thinks she should have complete control over the family, showing poor judgment, anger toward family, unwilling to give up any power to her husband for decision making? 2 teenage children involved, driving them all crazy. Yeah, I mean, I would try to get this family into some counseling where things could be talked about openly. Yeah, so I mean, this is actually a good example of how you can't say, well, you have HD and you're making some poor judgments about your family and you're getting angry all the time. Clearly, that's not what this woman wants to hear. But it would be helpful for a therapist to work with the family and maybe point out some of the issues. And yeah, this is a tough situation. It would be interesting too to hear more from the teenage kids about what they think is going on, how much they know about HD. It might be helpful for them to have that information as well. Hope that helps.
All right.
Okay. Any suggestions on getting an HD patient on a sleep schedule instead of being up a lot during the night? Well, you guys have tough questions. Yeah. I'm wondering what kinds of activities are happening during the day and whether there might be some more activity during the day so that the person is up and active during the day so that maybe they're sleeping more at night. Again, there may be this may also be a question to talk with a physician about, whether there's something happening with their sleep that could be assessed medically. Okay. Yikes. I think that was the Jane, I think that was the last question that I saw.
And the timing is perfect. There's about 2 minutes left, so if you have time, we have time for maybe one more question. But if anyone else has any questions that Anne did not cover, you can see her email, and you can definitely send an email to her.
And I'll answer.
Okay, so we have no more questions. Anne, thank you so much for your presentation, and thank you to everybody for attending, and please be sure to fill out the evaluation that you receive so that we can continue to bring you more of these webinar offerings. Thank you so much.